Members of the public, most of you regular attenders, thank you, and nice to see you back here. And I know Barbara's submitted a written question at the end. Some apologies before we start. I've got Steve West, Dave Perry, and Sarah's deputising for Dave, Will Warrender, and Stephen Peacock. Any other apologies that we've received at all that I'm not aware of, Rob? No. Okay, great, thank you. Just to say before we start, I need to be on a flight from Bristol at 5 o'clock, so I do need to finish by 2:30. That's not to stilt your conversation at all, because kindly Alison's going to step in if we start to go over. But I'm going to rejig the agenda slightly to make sure that if I do need to go, that at least I've covered the stuff on the committee updates. So I'm going to reorder the agenda to Shane's report, the committee updates, and then followed by winter planning, the conflict of interest policy, and public questions. So without further ado, if I just progress us into declarations of interest first of all. Is there any declarations of interest anybody's got or conflicts with the agenda today? No? Okay, great. Thanks very much. So we got the minutes of the meeting of the 7th of September. Is there anything anyone wants to raise about those, about content or accuracy, that were at the meeting? No? Okay, great. Thank you very much. So we've got 3 actions, one of them still open. That first one is around the ICB exec directors to consider a single reporting to committees. Deb, I know you updated this on the last committee, and the NEDs have been involved in it. I just wonder whether there's any progression to the point of delivery around it.
So it's now, in terms of one of our weekly executive meetings, we're going to be utilising that to factor into our performance discussions. And then the other part of the action was that there's a seminar session with the board. It's on the forward plan, and I know the seminar sessions, Rob's coordinating those. So it could probably be closed from here, I would suggest, Chair, if that's okay with everybody. And then obviously it will appear on the seminar sessions as and when the forward plan is agreed. Great, okay, thanks, Deb. And then there was 2 for yourself around the risk register, Sarah. Are you able to update on those, or are others going to update on them? So that was just about the board update of the papers. Yeah, for both of those, wasn't it? I don't think there's anything else on there. No. Okay, is there anything else from the actions that anybody else wants to raise or comment on? Great, thank you very much. Shane, over to you.
Thanks very much, Chair. So colleagues, as always, my report, I try to make it quite succinct about 3 big things are absolutely in the line of sight at the moment. 3 big things to discuss are organisational restructure of the ICB, winter preparedness and industrial action. I'm not going to go through the paper line by line, you all have the paper, but I just want to pull out some very important points. Colleagues will know that the ICB itself has to go through a restructuring. We have to reduce cost of the ICB by 30%. We have a process in place, and I've shared with the board at all board meetings, certainly for the last 6, 7 board meetings, is our restructuring process. You will note that we talked in our previous board meeting about having a single consultation for the new organisation in December and January. What I'm making the board aware of today is that we've slightly changed that process. We are going to have a short consultation on senior executive structures. That consultation will kick off next week. And will be closed over the month of October, and it is only consultation with our executive members, so our executive directors. It's not a public consultation because it's about the jobs that they have, and therefore it's a closed consultation on their jobs, with the intention of establishing the new executive team very, very early after the close of the consultation, so early November time, to be able to say this is the new executive management team. You will see in the paper, though, as part of our longer journey in looking at restructuring and what the role of the ICB is, I had raised at the last board meeting that I'd be meeting with chief executives, all partner chief executives, to explore where we take the system working to. And I've called out in the paper 4 areas that we've all committed to try to work over the next couple of months to explore how we could do these differently as a system hopefully in a more efficient and effective manner. And you can see the 4 areas there. How do localities work, and how is the best way for localities work moving forward? How we work very closely with One Care and look at primary care management and just try to understand the things that we might be able to do in that space. IT services to general practice, and then the whole idea of looking at continuous improvement and the resources we have in the system. So it's important that what we're looking at initially is looking at restructuring, but there is no point in restructuring an organization unless you think about how does the system work, because the organization itself is a very, very small, I hope important, but small part of a system. And what we're looking now is how do we look at opportunities for further system working. What I would say is we are still on target to do a full consultation on our structures with our staff, with all staff, at the beginning of December. And that is what we're still on track to do, Chair. So that's the first element of my update. And at the end, very happy to take thoughts, comments and questions. The other thing I should note, of course, is that we did also open the voluntary exit scheme, the voluntary redundancy exit scheme last week. And obviously anyone within the ICB can apply for the voluntary exit scheme. That doesn't mean that anyone will be accepted, but we have panels set up towards the end of the month in November to explore the voluntary exit scheme and people who may wish to exit on that scheme. Okay. The second big area then, I think, is winter preparedness. There is an agenda item 6.2 on the agenda, but I think it's important just from a chief executive perspective. A huge amount of work has gone into preparing for winter on a collective basis. So people from across the system have been involved, and it is fabulous. I'm very well aware that Lisa Madden, who was our director for performance and delivery, and last year was the winter director, for want of a better term, Lisa started a new job with NHSC on Monday and has left us. So what we are doing this year is that we are actually pulling together and making the winter director a clinically led process, and Joe as CMO and Rosie as CNO taking the clinical lead and actually taking the winter lead. So actually managing winter through Rosie and Joe, but strongly supported by Dave Jarrett as Director of Primary and Integrated Care, and strongly supported by Caroline Dorr, who's the Deputy Director in Performance and Delivery. But what is more important is that winter will not be successful by 4 people in the ICB. The whole idea of managing winter is the importance of the winter delivery group, the winter escalation group, and in fact chief executives as senior leaders being prepared to step in. But you will see from the paper under item 6.2, we have assessed ourselves against winter, we've plans for winter, we have invested heavily already, and therefore we are in a strong place for winter. However, winter still remains a considerable risk and challenge. There's no doubt about it in all health and social care systems, including our own. And then the final bit in the report, Chair, is about industrial action. And people will be very well aware that certainly this week, both consultant and junior doctor industrial action for 3 days, 2nd, 3rd and 4th of October. And with previous industrial action, clearly, we have what I'm going to consider a well-oiled process now for preparing. But I think it is really important that this board recognises now that it is becoming a place where I think avoiding harm is becoming remarkably difficult. I think it's very clear now that the length of the industrial action and also the combination of both junior doctors and consultants is resulting in considerable elective cancellations. I think you used the term 7,000 outpatients this morning, Maria, when you were talking about NBT. Considerable procedures are being cancelled, and I think it's very clear those procedures are also having a direct impact on patients. And most recently, and you may have seen this in the press, a letter from NHSE which went to the BMA to really stress the importance that a lot of the cover, which would be called Christmas Day cover, and that's the way that we've been looked at. Christmas Day cover for 3 continuous days of Christmas Day doesn't make sense. And the idea that we could ever run an effective and safe health service on a Christmas Day cover really has proven remarkably difficult. And I think it's fair to say in NBT and in UHBW, particularly NBT this week, the impact of a very, very busy environment plus 3 days of industrial action on unscheduled care has been considerable, and has caused considerable waits, considerable challenges, ambulance handover, despite the effort from everyone in the system and the amazing effort from the system. We know that has caused difficulties this week. So I think it's really important, Chair, that we have on record our thanks to everyone who's involved, but to genuinely note, as NHSE noted in their letter to the BMA, we are now at the point where industrial action is causing harm. That is not to get political, and the issue is between the BMA and government, and therefore this is not a political statement in any way. It is a factual statement that we cannot continue to cancel care and expect to have the same outcomes for our population. Now, it is not within our gift to fix it, but the board need to be aware that the impact this is having on our population is now getting to a point where there is evidence that this is causing harm.
Okay. Thank you, Shane.
So I'm happy to take thoughts, comments or questions, Chair, from anyone on any of those 3 items.
I guess, Shane, a lot of that is very self-explanatory in the way you've set it out and very clearly, but any observations or questions from anybody on Shane's update?
Ellen?
Ellen?
Just one on winter preparedness.
Yeah.
In your report, Shane, you talk about lessons learnt, and,
Yeah.
and it's a really good report, and I think, you know, the winter preparedness, you've clearly articulated the work that's gone into that. And the priority that it's a system-wide initiative. You talk about one area, which is getting under the skin of the causes of no criteria to reside. And I just wonder whether you can say a little bit more about that, where we are on this journey, and whether we're in good shape going into the winter period to understand where we are at any given time and the ins and outs, sort of, you know, with Serona.
I think what has been evidenced is that in terms of our improvement in no criteria to reside, it is considerable our improvement in our front door measures, which are connected, front doors are connected to the back door measures in terms of 4 hours in A&E and ambulance turnover, has shown over the 12-month period a considerable improvement. And that's fabulous, okay? However, it still shows a considerable further room for improvement. And that's why we invested, as we did, the £36.5 million at the beginning of the year on things like transfer of care hubs, really working with Serona on D2A, discharge to assess, and making sure that process works. So we are on a continuous improvement journey, and when you look at the last 12 months, that can be clearly evidenced. I think what we now have, though, is we're heading into a really hard winter. And what we have to be certain is the work that we've put in, and a lot of the work through Dave, through the Director of Primary Educated Care, through David Jarrett, clearly shows that, you know, we've made investment. We know and modelled that investment will work, but it is going to be a hard winter. But we can evidence the last 12 months we have had continuous improvement in the unscheduled care flow. And the lessons learned from the 7th of September meeting, which is what's referenced, one of the positives that people did say, well, actually, we really got under the skin of no criteria to reside. We really began to understand what causes delay. And so when I say we, I don't mean the ICB. I mean we as in Chief Operating Officers, Director of Adult Services, we in the system. And in fact, there was a meeting last Monday that I wasn't able to attend because I wasn't well, but I know, Sue, you did attend, where we presented that back up to the National Task Force. And maybe, Sue, you could just reflect a bit on that meeting.
More than happy to. I'd agree that great improvement has been seen. You were an outlier, you're now not, which is good. But as Shane said, it was recognised that there's still work to be done. But the grip of where we are now compared to where we were, an understanding of the improvement programme is much better than it was. So I think that everybody recognises the amount of work, and you were commended on the amount of work that's been done to get to where you are now, but recognise also there's more work to be done.
Okay, thanks. Thank you.
Any other questions or comments for Shane? No? Okay, I'll move us on then, if I can, to the committee updates. So let me start with the Integrated Care Partnership. We talked about some of this at the private board, but as you'll know, the Integrated Care Partnership is chaired by the chairs of the Health and Wellbeing Committee. So it was North Bristol with Mike Bell last time. It's now passed to Helen Holland from Bristol, and then we'll pass to South Gloucester. The intention of the Integrated Care Partnership is about setting the strategy for us, which has been done with a massive amount of effort from Colin and his team in producing that. We're at a stage now with the ICP where we need to get some clarity on what their role is going forward, as well as how it complements and works in tandem with this board as the ICB. At the last meeting, we had 4 substantive items, really. The first one was around the Integrated Care Mental Health Strategy, which Julia Chappell presented, Dominic, from AWP. There was a little bit of confusion there about what the role of the ICP was, but it was about to signal the consultation around it, rather than decision-making around it. But it was a well-received presentation, and I have to say, she put a huge amount of effort into that, so worth going back and congratulating her, because it was outstanding. The second input was around the Voluntary and Social Care Enterprise Alliance, which Colin has led for us with the support of our voluntary sector. Now, in the Integrated Care Partnership, there's probably about 8 or 10 members there who are from the voluntary sector, and they really are coming together to have a bit more of a joined-up view of how we should be delivering our health and social care. I mentioned this to the private board this morning, but it might be timely that we consider how that is represented back here at the Integrated Care Board, and that touches on the point that there was raised about making sure that we have an away day between the Integrated Care Board and the Integrated Care Partnership to try and ensure that we are complementing each other in the way we're moving things forward. And then the final presentation was from the Black South West Network, which was very interesting, around just a little bit of pump priming and support for that network, how that had opened the doors for people from BME communities, particularly Sudanese, Somali communities in Bristol, and the impact that had. So there was direct outcomes in that. It was a very interesting presentation, and that took up the majority of our time. I would say with the Integrated Care Partnership, please continue to ask your chairs to attend the partnership. There's a lot of people there, and there's 4 or 5 of us around the table who attend that partnership. But I think it had an opportunity to demonstrate how we are engaging our communities in a different way. So that was just the ICP. Just any observations or questions from anybody? No? Okay, thanks very much. I'll move on to the Finance Committee then. And I'll come to Sarah in a second, who will update on the midterm financial plan for us. Steve West was unavailable last week, so I had to step into the chair for him. And there was a number of substantive items, some which have featured on the agenda this morning, but some which I would update on. The first was around funded care and the deep dive that was done on that. A lot of conversation there about who does what and how we apportion responsibilities. And I think more will come back to this group at a later stage, but I know Sarah's been involved in that. The second is the one around Home First, and an update on Home First and how that's progressing, which I think, and I'll come to John in a second as well, I think the Fed were very interested in that and also very reassured about the work that was ongoing in that respect. The third was around the cost of industrial action, and we do know that between May and August, the cost of industrial action just on backfill pay has cost us £5.5 million. So, you know, that is not an insignificant amount of money, and that is something that we haven't factored in financially. So it's bound to have a detrimental impact down the line. And I'm sure Sarah can talk about a bit more about that in a moment. We then looked at the mental health VSE contracts and the award for those contracts, which was supported by the Fed group. And then finally, the input from Deb around the shared data planning platform, which again demonstrated real progress. And I think the committee there were quite impressed with how that is being taken forward. Sarah, I'll pass to you and then perhaps open to any questions.
Thank you. So I guess the first thing I just wanted to update on was just around the medium-term financial plan that we signed off here as a board. That was submitted to NHS England after our board meeting, and the feedback we've had has been very positive in terms of the maturity of the approach that we're taking in BNSSG and the work that's gone on. So just wanted to feed that back. Then probably I just wanted to, you've got in the papers the month 6 financial report. we are significantly off plan. Probably about over half of that is down to the industrial action, and we have formally escalated our concerns about, we've had notification back a couple of months ago about the adjustment that was being made to our elective services recovery funding sort of target to take into account industrial action. That only covered the industrial action up till the end of April, but also even that, it's so complicated in terms of the analysis that we've received from the national team that I'm not really able to give you a very clear position on where we are with that. So we have escalated it formally. We are meeting again as Directors of Finance tomorrow, and we'll be escalating it further, because I don't think it's acceptable for us not to be able to give you as a board a really clear position of our forecast outturn position. Obviously, you'll have seen in the Health Service Journal that there are negotiations going on with Treasury about the additional costs of industrial action for the whole of the NHS. So, you know, we are beholden to wait for that. But I included in the papers this month the consequences of not delivering our financial plan. So while we've got that uncertainty, we have to make sure that we are doing everything to deliver what's in our gift and what we said in our operational plan. So that's the savings delivery, and we've had some improvement in that this month, but we've got more to go, and so really keeping that focus on. We also have significant costs around agency staff, and we really do need to get on top of that. We've got some really good work going on, and we've seen some reductions in some of our nursing agency, but I think we've still got some challenges both in terms of medical agency, but also in particular organisations, and I know particularly in AWP, and I know there's more work going on there. And then primary care prescribing is becoming a challenge as well. That is a national issue, but we are working across the South West. We met last week, there was a meeting of prescribing leads with all of the Directors of Finance to really go through what everybody is doing to make sure we are doing everything we can to contain those prescribing costs. So that's really the areas of our focus. So I just really wanted to draw out those points.
Okay, thanks, Sarah. John, anything to add from your perspective from the Finance Committee?
I think the one thing I would say is that we had the conversation about the pressures and about being off plan this year and about some of the the issues that may be developing for next year. And I think that we were very clear as a committee that we absolutely have to deliver in this year, so that we ensure that we have those 2 cumulative years, and that is the the huge prize for us as a system and for the people that we serve in terms of being able to to get the debt written off. And if we have some really difficult conversations to have, it's next year. It's not it's not this year. We must deliver. We must deliver this year. And I know Steve would say the same thing, because he has been saying it all through this year. So I think that's really the absolute kind of key takeout.
As you had at the board last month, wasn't it?
Yeah, absolutely.
Around the historical debt and the impact that'll have on us.
Yeah,
Dominic?
absolutely.
If I could just comment on AWP, we had a conversation last time, and I don't recall whether it was in public or private, but I'm very happy to have it in public, that AWP was tracking behind plan due to us consciously diverting attention onto urgent quality and safety matters in Q4 of last year and Q1 of this year. We have now remobilised our cost improvement plans. We've got very clear plans that they're costed. We're in delivery. What I can't give confidence about yet is the lag between delivery and the result, but we'll be tracking that very closely. So I'll happily update whether through the FED, is it FED, if that's the right name, or directly here, probably around the end of this quarter as to how that's going. But we're absolutely going for it. We believe the opportunity's there. It's just capitalising on the opportunity, really. Thanks,
Dominic, and I know Sarah will, but I think with Steve West, just ensuring that we are continuing to shine a light on that, because it's just easy to let it slip, and it'll have a very negative impact on us. So, Ellen?
I think Dominic's probably just addressed my query, but it was to Sarah really. October probably a really key point in the whole financial year in terms of understanding the challenges between now and the end of the financial year. What process do we have in place for some of these sort of overspends? Are you confident that we will land at the end of the year, and is there an escalation process?
So I think that's the issue in terms of the escalation that we've already done around the the impact of that change in the elective recovery, because while we're not able to understand that, we're not able to do the work that we would normally expect to, Ellen, and that's really, we would be expecting at this point to be doing a really clear forecast of our position, and we just feel that we haven't got the information to do it properly. So that's why we have already escalated, and we will re-escalate that. But yeah, absolutely. And you'll remember that there was a protocol released about the sort of steps that you need to take. We are working through that as Directors of Finance as well, in terms of making sure that everything is in place to do everything we can to secure the position.
Thanks, Sarah. Any other, Deb?
Just a couple of things on the digital agenda, just to highlight. So one is, which I think the area that affects the most is probably AWP. We've had a piece of work going on around advice and guidance for a number of years. The agreement was that we put down the business case working because in the majority of the system there isn't appetite and there isn't money to be able to fund an advice and guidance solution. It creates a risk for AWP as you straddle two ICBs. So we still haven't got to the bottom of how we mitigate that, which we're going to need to. But at the moment, there isn't any funding that's allocated to advice and guidance. There's supposedly new things that are coming through on ERS that we get for free from the centre, but we are going to need to work that through in terms of what it means for mental health and connecting through in terms of the community mental health framework. So that was one thing to flag, that business case work has stopped. As we've all said, there are some things that we have to stop doing. The other piece to flag is that there was a joint technology-enabled care bid that went into DHSE on behalf of all three local authorities. We hope that if that's successful, that could be up to £700,000 to be able to support us in terms of some of our ambitions around technology-enabled care. Not just about the technology, a component of that, we need to make sure, and that's mandated from the centre, goes to evaluation, which is one of the things in our technology-enabled care ambitions that we wanted to be able to do. And then the final thing was there's 285,000 that's come into the system for cyber. The cyber group, which we've got a joint cyber group, are working through what that is most valuably and the biggest impact of where we spend that funding. That's going through the Digital Delivery Board in terms of sign-off, but obviously we will connect back if there are any, is there anybody who's particularly interested. But given the value, we won't bring it back here, but we will bring it back for information. And it is likely that it's going to focus on the areas that in our digital maturity assessment came up as being our areas of most significant risk as a system, is where we're going to prioritise any spend that we have available. Thank you.
Thanks, Deb. Any other comments or questions on finance estates of digital? Okay, can I move us on to People Committee then? Jay, do you want to start us off, or Joe? I said, either way, really.
So I'm maybe aware we were pleased to host a long-term workforce plan roundtable for the system towards the end of last week. Very productive and focused few hours, which included our educators, providers and system partners, as well as social care colleagues. So a real opportunity to come together to look at what is contained within that strategy, but more importantly to understand how that how we can create a BNSSG response to that has an ambition for our system, and that goes beyond actually what is contained within the plan. So involving social care and moving across into a voluntary sector and as well as part of that conversation. It was the first discussion. There's much more to do, but sort of in terms of outcomes from that particular session, absolutely a willingness to collaborate, which was really clear and really strong. Some very tangible agreements to the thinking, what does that people and culture response for BNSG look like? So a plan for us to get together to start to co-create that within our own context, and a sort of a focus on expanding what is work around a learning and leadership academy into a broader people academy, and using the people programme board, a refreshed approach to our people programme board and our people plan to galvanise that action. That was also then a move to us being an anchor system, which obviously supports the aim of the ICB around social economic development, as well as considering our workforce and us as a group of employers of choice. So more to do, and we will obviously continue to route that through the People Committee, but a really, really, really positive start.
Thanks, Joe. Jay?
Great. So, to add to all of that, we're obviously still doing the monthly workforce monitoring. So we were above plan for August, and there was, due to growth in clinical support roles, we've had strong international recruitment, and there's a downward trend in turnover. I'm starting to sound like a weather forecaster. I do apologise. So our committee had some really good focus sessions, two focus sessions. The first one was on the BNSSG GP 5-year strategy. Ruth, thank you very much for that. It was very well received, and it connects to everything that we're already doing, and it's pretty key for us to deliver on the people and culture work and the future of the training hub model in the system. The second that we had was the social care deep dive and the work the Leadership and Learning Academy is supporting. I have to say this was really, really well timed, very, very good, and there was a huge range of impactful work that we learned about during the session. So some key takeaway points were that we know that workforce transformation must be co-produced with producers, commissioners and locality partnerships. So we need to make sure that what we're doing with the People Programme Board is woven into all of that. Key challenges to recognise within social care is that it's not, as we all know, it's not integrated in the NHS long-term workforce planning requirement. So there's no overarching strategy for social care workforce. And that means that projects are developed in silos. We have to recognise, and we all do, I think, recognise that there's a huge amount of healthcare that occurs from this sector that covers what we do. And it was pointed out that there was need for parity of national investment in training and development to the sector. So we can, as a system, start to do this kind of thing. Short-term funding is rife across the board. Reduced funding for workforce transformation and innovation within the social care. Other challenges that are to do with perception of social care, so getting people into social care is a thing. Parity of esteem as well in terms of conditions. Lots can be learned from what we're doing within the system and what could be spread out towards the social care sector. And they did cover many opportunities that were there to ease the winter pressure, so we should be building in some of those bridging partnerships to create new capacity. Also, in terms of EDI, for the first time we're creating a system EDI report. Historically this has been done by organisations locally, but we want a system workforce view. Jeff, I know you've mentioned it before that we need to, and absolutely agree, we need to drive this forward and keep it on the agenda. So the People Committee will receive this report at the end of November, and this will then come to main board for discussion early in the new year, if that timing works. Finally, I attended a workforce planning session with Bristol City Council across the city region on health and care workforce. And one of the key things were highlighted was that the BCSE need more support in order to engage with some of the skills contracts that are coming out regionally. Otherwise, we will start to see national bodies take in that space, weaken our sector, and we need them. BCSE is our biome, we need them. So if we can keep that on our radar, I think that would be really helpful. So that's it from me.
Okay, thanks, Jay. So one question for me, Joe. The workforce session that you held at Engineers House, really well attended, massively high energy. The time went very, very quickly. People were brimming with ideas for what we could do collaboratively. My question is, the so what? So what is happening with that information? So, for example, Jackie from MBT talked about shared services. Now, we may support that, we may not. But how are we getting some of those ideas threshed out in a bit more detail?
Yeah, so our current SRO model, which operates across the system, will take some of those actions forward. They're still being written up, Jeff, because they were captured on tablecloths, as you all know. So we're still pulling that into an semblance of what sort of clusters do those ideas and some of those actions have. Some of those we will already be doing in part, I think. So it's about how do we add to the work that's already be underway. It's also about building on opportunities like with the work being done around the corporate services model from the acute provider collaborative, because we have that in our sites, as we do with the collaborative bank work as part of the temporary staffing work. So there are numbers that I think we can mature that's already in place, and there are some things that might be new, and the idea of the expansion to include culture work and to think about how we look end to end at sort of portfolio careers and and keep people working within our system but maybe moving around our organisation is something we will take forward. Crucial is the leadership. We will be looking to the people business committee to do that. That will be People Programme Board, rather, I apologise, People Programme Board to do that, and that for that signalling the change in the strength of that as the real engine room behind it is our first step, and that's taking place on the 16th of October.
So decision making and governance on any ideas that might come out from that group are going to go through the people workforce.
We'll go to the People Programme Board,
Okay.
and will be held, and we'll report into the People Committee.
Yeah.
Great, thanks. Really good. Ellen?
It's a broader question, so it's not necessarily for a bit, but you might be able to answer it. I just wanted to sort of get a feel for where we are on workforce, because I know a few boards ago we used to talk about workforce an awful lot, and I just wanted to get a sort of a feel for how partners are feeling at the moment in terms of workforce and what health we're in. I just wonder whether anybody would offer that up, whether it's Sarah or the acutes or AWP. Where are we in terms of numbers running up to winter pressures and recruitment, etc.?
It's a big question.
Right. But, you know, are we better than last year? I suppose my question is, are we in better shape than last year?
I go back to Joe, really.
Yeah.
I still think there's some major challenges around the amount of people that we've got in temporary contracts, the recruitment, the retention of people. There is a seminar today to discuss it, isn't it? I think you're right, Dominic. I think it is one that Joe needs to keep a real tight focus and grip on, and then I think Eugene, in chairing the people group, will be really important about how we drive that forward. I can see. I think it's a good challenge. I think if we go to individual organisations now, we could have quite a long
I think
response.
my same point to Sarah, that October for finance is a crucial time. October, in terms of winter pressures, is a really key time in terms of, you know, if we're sort of not there now, then we're in difficulty. So that was just my feeling of just trying to get...
Joe?
So in terms of the overall picture, we are keeping a monthly monitor on that. The update features in the performance report as well as in the People Committee. So it is available to board every month. We are above plan. There are some reasons for that, which has been very much focused activity on international recruitment. Yeah. It's also been a real drive around turnover and sickness. So those are, you know, the trajectory is good. Yeah. Will the trajectory stay there? You know, that's why we're monitoring it monthly in a hope to, and then obviously working with provider colleagues if there's anything that is specific that we're noticing as part of that monitoring. But in terms of what we had planned, Alan, it is on track.
Great.
Okay, thanks, Joe. Sarah, did you want to come in then?
I was only going to say that we just had planning day 1 on Tuesday.
Yeah.
Ellen, I'll circulate to the board the report that went to planning day 1 on where we are against our operational plan, because it'd just be helpful. But it is, as Joe says, it is positive.
Great.
Okay, thanks. Any more questions on the People Committee update? No? Okay, thanks very much. Can I move on to audit then, John?
Thanks, Chair. We have the June minutes. I previously verbally reported on them. They closed out the previous year, and they were part of our formal business at the last ICB meeting, so there's nothing further to add on those. We had the most recent audit committee on the 15th of September, and there's three things really to share. We had the annual external audit VFM assessment presented to us, which is an independent look at our economy, efficiency and effectiveness. And pleasingly, there were no significant weaknesses. They identified some suggested improvements which are going to be taken forward, but generally that was a good positive read. Two things to share in respect of the internal audit updates. The first is that we received a pharmacy, ophthalmology and dentistry commissioning readiness to operate review that the internal auditors undertook, and again that was a good report from which I think we can take quite a lot of assurance. It was pleasing to see that. And then the final thing to share is that the internal auditors, because of the fact that they cover so many ICBs, they're able to give us some really helpful benchmarking information. And one of the key things that they pulled out really is that we are achieving fewer substantial assurance findings than other ICBs. But when we got into it with the internal auditor, it was really apparent, and what he really confirmed is that it is how we are using our internal audit function. We're shining a light into areas that we're concerned about, and we're getting the consultancy, the added value from that, and it's giving us the the material to take forward. So I don't think there's anything of concern there. I think it quite the opposite, and I think the message really would be to the exec, when we're putting the the audit plans together, think about those areas that you're concerned about and where you can get that that assistance from the internal audit. So generally, it was a good, positive meeting, and it nicely didn't focus very much on finance. It was much more about the the broad aims of the ICB, which is where we want to be. Thank you. That's it.
Yeah, thanks, John. And having been at the committee, it did feel very positive, both internal and external audit. There were some challenges, and as you said, but it did generally feel very positive. Any comments or questions around audit committee? No? Okay. Oh, sorry, Sarah.
The one bit, sorry, John, if I zoned out, but we received the auditor's annual report, and that will now be published on the ICB website.
Great. Thanks, Sarah. Unless there are any other questions for John, I'll move on to Alison and the Primary Care Committee.
Thank you very much. I've got a verbal update from Primary Care Committee from the 26th of September. As always, excellent support from partner non-executive directors, and it was Ellen's first committee, which was really good. 4 points to bring out. One is we had a presentation from Health Watch, which was really focused on case studies, some really positive case studies, and then some where experiences could be better. Really good to hear that Health Watch are aligning some work against the GP Access Recovery project. So they will be asking people their experiences as the GP Access Recovery plan gets implemented, which I think joining the dots is something that was really important to committee, that there's such a lot of data and richness. How are we using it to make decisions? So those connections were really helpful. We did look at the progress and the GP Access Recovery plan. This is a really important plan to stop the 8 a.m. rush, increase patient satisfaction, and allow GP practices to function more in a digitally enabled age. There is a board paper coming on the 2nd of November. There is progress being made. In some areas, we're better in our system than the Southwest. In some areas, we're worse than the areas in the Southwest. But it was really good to see the first iteration of the RAG rating. So it should be, we should expect progress to be more, and the RAG rating to be a bit more sophisticated. But so there's an improving picture, but there are clear unacceptable variations in practice still. So we're keeping an eye on that. But I don't want to steal Dave's thunder, but it is an important piece of work for the system, especially coming into the winter. The third thing was around dental, and it was really good to receive a report on a strategy development workshop where all the right people were in the room to discuss dental services in BNSSG. Lots of parties there. 4 main areas of improvement focus. We heard about improving access and addressing variation, the workforce, population level oral health prevention, and integration and collaboration. We saw the first output of priorities. There's a lot there, so I think it's a funnel, and I think it's going to get a bit narrower. So there's going to, but one of the striking pieces of data around BNSSG, which wasn't striking in a good way, was the proportion of 5-year-olds with visually obvious tooth decay from 21-22. We are the worst in the Southwest. Bristol is deep red in RAG rating. North Somerset and South Gloss are just behind on dark orange. So it's not great. It's really not a great picture. So we will want to see that the emerging priorities that come out clearly hit the spot where we've got the need in our population. But it was a really good to receive the first really time of everyone coming together with a BNSSG focus. We had an update on the winter planning GPCB urgent care network update. It was really good having a split of 4 different areas. Interesting to talk about the collaborative bank that Maria's mentioned this morning, and I think Joe mentioned this afternoon. There's a collaborative bank in primary care where they've got 9 practices currently involved, but the lead there is firmly in the system collaborative group, so the connections again are being made. I've talked before about the assurance we got on the acute respiratory project a couple of months ago. We asked them to look at what would be different this year based on the learning from last year, and there was some really good examples of things that would stay the same with the acute project and things that would change. So practice level rather than PCN level, and an extended opening of the acute respiratory function from November to the end of February. So some really big differences there. So it was good to see the learning from last year. Those were the four main things. Did want to say that there's been practice in our patch which has struggled a little bit with Care Quality Commission ratings over time, Green Valleys. It was so pleasing to see a good Care Quality Commission report for Green Valleys. The practices have worked so hard. The support from the ICB it's been a long old haul, and it was just I couldn't let the moment pass without acknowledging it, because it's a big achievement.
Okay, thanks, Alison. Dave?
Alison's covered about just to re-emphasise the kind of dental strategy workshop and commitment and engagement from partners in the room. We had a number of actual dental teams in the room, public health teams, and also Jeff, engagement from the new dental school. We went to the opening, and so we've got. I think there's a will and a way to look at dentistry services differently in our system. We've got some great opportunities to harness. We're still working within the national dental contract, and so we have to work within the realms of that. But we are working to to work within that to increase access as soon as we can. And my next session tonight is with a group of dentists in North West Bristol, so I'll keep that conversation going. But we're definitely moving in the right direction. I think it will draw out when we come back to the recovery plan next month as well. But I guess we have focused on kind of general practice and dentistry here as the biggest service, and then the one with the most challenges. But I think we should also, when we get to the recovery plan, draw out the amazing progress that's made in our community pharmacy teams in terms of the community access to new services and the support that they are offering the system going into winter. We are exemplars in the way that we are utilising and accessing community pharmacy, and I think we should note that, and we'll come back to it next month. Then they probably don't get much attention here, so we'll make sure they do next month.
Okay, thanks, Dave. Any comments or questions for Alison, Dave, or others who are at the committee? No? Okay, great, thanks so much. Ellen, I know we didn't have an outcomes performance committee and quality committee, but any updates?
Just that I reported at the last board on the last committee that we had with the next committee in November. We've moved to bi-monthly, however, I do meet with the executives to talk about performance. Urgent care, as mentioned earlier, continues to perform very, very well, and it's a transformation from last year, so that's a real positive. We have challenges in cancer and elective. We've rehearsed and discussed two key courses, which Shane alluded to earlier on, which is industrial action, as well as we have a challenge in dermatology that we are working through at the moment. So those are the two key areas of performance. For November, we're going to be looking at, as well as keeping on top of cancer and elective, we're going to look at no criteria to resign home first, the winter plan and the operational plan. I know we're going into the winter plan now, but we're going to cover that again at the next committee meeting. Great,
thanks, Ellen. Any questions for Ellen? Comment? Anything from exec team members on? Because I know we have another meeting, and we'll probably cover some of it now on winter planning. So, no, okay, great. Thanks so much. Thank you all the chairs for the committees, and having sat on nearly all of those, they're really starting to progress quite nicely. There's a good blend there of engagement from NEDs from outside organisations and execs from your different organisations, and so there is that opportunity for those committees to do that detail that we never get the space for here, because physically we haven't got the time. So yeah, thank you. If I can move us on to winter planning, I think we're going to have a bit of a treble act on this one with Joe, Rosie and Dave, if I'm right. So I don't know who's going to start us off. Joe, are you going to start us?
My diligence just closed, so
Sod's law.
Joe is going to have to help me with this. It's typical, isn't it, honestly? I'll be all right, I've got it here. So this is really a highlight report, just trying to sort of put down in a board paper some of the things that Shane described in his Chief Executive's report. It is for noting. What it doesn't have in it is the national submission that was sent in on the 9th of September, which has got much more detail in. And what I was going to suggest to the board is that we take it through the Outcomes, Performance and Quality Committee for a bit of a deeper dive, further scrutiny of it. And then between Ellen and I, we'll put a note back to board to say if there are any areas of concern and are we assured with the progress that's been submitted up to the national team. So just actually noting that admission in here, what you really have is just to say the 4 areas that the national team asked us on and the response of the system. It talks about recovery champions, it talks about having system control centres, the clinical rotas all in place, and we've all responded as green on those RAG ratings. And then it talks about the reflections from a workshop that was held, I think it was in the middle of September, by the performance team, and just highlights, I think, some of the issues that we know are areas to be worked on, areas to be improved. And Rosie and I, as we take the clinical lead for winter over this, supported by Dave, will build on those reflections, build on those issues. We're kicking into the silver gold response to winter, which we did last year. We go from monthly meetings into weekly meetings, and all system partners are always very well represented around, especially from the chief operating officers, from the providers. But that's kicking in now, and we can start to make sure this work is embedded. Other than that, I think I'd just be happy to take questions, especially as I haven't got the paper in front of me because I can't see it.
I'm looking at Rosie and Dave, whether there's anything to add to that. I mean, there's a good indication how that's going to be managed through the committee, but...
I think what I'd add, there is a... the full winter submission is a comprehensive document which covers winter planning from all sectors sat around this table, and it gives a high level of assurance of those plans going into winter. This, as I say, paper draws out those kind of 4. So nationally, I think there were 10 high impact interventions and support offered. This system has picked out those 4 areas as detailed on page 31 of board pack. So as the areas where we would value kind of external support or indeed offer support in. So that's how we've got to those 4 as part of this wider kind of 10 plan package from NHSE. But all of those services are embedded in the overarching winter plan. We'd already, in terms of kind of areas that I'm overseeing, already discussed winter mitigations related to the Discharge to Assess programme, which we'll come back to next week. And I'm personally, we discussed this here last month as well, working with the NHS at Home team with Sue in terms of making sure we're maximising and optimising access to those services into the winter as well.
Okay, thanks Dave. Rosie, anything to add?
I would just reflect on we've got a new Opal framework that's got 9 measures in it, which are all about adult acute flow. So whilst those are set and they're what we will use, I think what we will need to do through our system groups is make sure we look at the whole system, and the whole system is changing, particularly children, adult social care. So our silver gold framework involves us all, and we'll just need to make sure in those conversations we reflect the flow and the pressures inside the system as opposed to just those 9 adult acute. We know we had real pressure inside children's last year, so we just need to make sure we take that and then we build on it so we are managing our system really effectively.
Yeah, I think that's a good point, isn't it? We do need to recognise what the national direction and challenges are, but we need to reflect locality.
Yeah.
That's good. That's a really good explanation.
Yeah. We had a good discussion of it in the system quality group last year, and I'll make sure we pull that through into this year.
Okay, thanks, Rosie. Any comments or questions? I mean, obviously this will be coming back to us. Alison?
Just a question which probably the answer can go back through to committee, if that's okay. Just on the slide around reflections on last winter, just a little bit more on the reactionary approach to patient safety and how you're making it different this year. So it feels like we need a bit more detail there, but like I say, it might be better going through committee.
Yeah, I think we need to, because I don't know how many health and care practitioners were in the room for the winter planning grant. I know my deputy CNA was there, so I'm happy to pick that up in conversation with colleagues and make sure we're right, because I probably wouldn't characterise it quite like that. There are systems and processes inside the providers to managing patient safety on a proactive way, so we just need to kind of check in on that and take that back through. I was just reading the words in the report. Absolutely, yes, I agree.
catastrophe control system that will do a bit of forecasting for us. So there was a lot of spot purchasing of beds last year to react to system pressures, and I think we have got a way of actually at the end of every, well, as we're going into the weekend, we can predict a little bit more what does the system need, and some of that is another reference there about the chief nurses leading work about looking at workforce movement. And do you remember last year we talked about movement of therapists in particular from acute into community to back for the community services so they could pull. And it's all of that, I think, is that miss. But we do, I said, Rosie and I sort of, we started this on Monday, so we just need to unpick some of that a little bit and understand from the team that were in the workshop what the words mean. That's what I think it means, but again, I think we need to spend a bit more, I need time to tease it out.
And that's why I go back to those key lines, those Chloe's in the OPAL measures, is actually making sure those are a bit forward so we aren't reactive to patient safety. If we're looking at the system, then we can respond appropriately no matter where the pressure is, which is why that will need to be expanded out a bit broader if we're going to work the system effectively together.
Okay. Thanks, Rosie. We've got John and Maria.
Thanks, Chair. Same slide, reflections on last winter. I'm not sure who to address this to. It was just the opportunity around burden of national reporting and whether we're seeing any helpful developments in that respect, and in terms of the reporting that we do, what happens with it, what happens as a result.
Good question. I don't know whether is that for you, Joe, or for Shane?
Well, I think all we can say is we'll take it back to Caroline and Greg. I don't know the answer to it, John, but I'll take it and I'll get back to you when we do that sort of wrap up and the slightly longer deeper dive. I can take that as one of the further questions.
Yeah.
The national reporting is set out in one of the appendices, but again, I don't know whether that's more or less than last year, because as the two sort of lead, we haven't been that close to winter last year, so we just need to
that's fine.
to see it in a bit more depth.
Shane?
I think it's important to note that certainly through the work that has been done with Mark particularly, is there's a commitment to try to reduce the national reporting, okay? However, I must stress that in many cases it's not within the gift of the region. In many cases it is genuine national reporting. And if it's genuine national reporting, unfortunately we struggle. Now what we would like to be able to do with the creation of Foundry, which was the sort of single view of data across the nation, I'd like to think that it's much easier for information to be sourced at a national level rather than fed by the local. Okay. However, at the moment, and I'm speaking very honestly, I haven't seen a lot of evidence of that yet. Okay.
And if, in fairness to Mark Cook, he does push back.
He's trying to. He really is trying to make this burden as low as possible. Yeah. But some of it is genuinely national. We know, I mean, the reaction on Monday to some of the unscheduled care pressures, it were senior national leaders wanting to know what's happening in that emergency department, in that city, in that town. There will always be that national desire.
Conceptual step in the right direction, and it will take time, but hopefully we will
Maria?
ultimately get it.
I think in relation to the patient safety issue and what we learned from last year, I do think the kind of quality impact of spot purchasing does need to be looked into, because actually it's one of our main mitigations for some of the procurement exercise we've put forward for this year. So if it was seen as reactionary and potentially compromising patient safety last year, then I would want to signal that we perhaps need to put a bit of time and attention into that. The other bit is just about the OPAL framework and the new 9 metrics, because actually pretty much on any given day, if I run NVT metrics through there, we're in automatic OPAL 4. And we can't exist at automatic OPAL 4 because the shine comes off very, very quickly and the response to it blunts very quickly. So I don't know if there's a way of feeding back around this framework, but I think it does put most trusts into a very high level very quickly because of the tolerances, which, cumulatively do add us up.
Yeah, so I think what the national solution was, there's 19 metrics in the current open framework. We're going to do them in parallel. So what we can do, Marie, locally we'll use the current 19 metrics, so we'll have our current system, which everyone's very familiar with, but we'll just do a little test and learn with that, and then we can feed back at the end of the winter, say, well, actually, look at this discrepancy, the disparity of the alignment. So we can do that, but it was, I think, agreed through the workshop that we're going to run both, just so we don't. Also, this is not the time, is it, to do a different framework? So we're going to do both.
Okay, and then Sue, yeah, I'm sure you're okay with it.
Absolutely, and it has similar comments have been fed back, similar comments about its very adult acute basis, and it, you know, the way it's phrased at the moment, everybody in the country will be in Opal 4 all the way through. So I think we need to see this as a bit of an improvement journey and hope that that we're able to look at it.
It wouldn't be in it at all, would they? So no, it's, yeah, we're going to do both.
No, they just stand it up in summer as well as winter.
Yes.
We have it all year round.
So we're not being asked to decide anything on this today, just a discussion. I think we've floored that quite well, and we can see the path through, but it will be coming back into us here at the board, won't it?
And I think what's really important, agreed with Joe yesterday, is that the Performance Outcomes and Quality Committee is the place to go into the detail of assuring on the overall plan, and absolutely that needs to come at the next committee. So you can then, Ellen, come back to the board and say, I've seen it. I'm 100% certain it's right. Exactly.
I take full responsibility.
I take full responsibility. Yeah, but it is important that the committee do have genuine time to dig into it.
I've just rewrite the agenda as we are.
Wonderful, thank you. Thank you very much.
There we are, positive then, wasn't it?
Yeah, thank you.
Okay, thank you, everybody. Let me move us on then to our final substantive item of the conflict of interest policy. So, Rob?
So the conflicts of interest policy was received in line with our scheme of reservation and delegation. It's an existing policy, but the scheme of reservation and delegation agreed by this board, which means that some policies get agreed by the board, some get agreed by the chief executive, need to go through a committee. The audit committee reviewed this policy, which was updated. There are minor updates to it, and it's likely that it's going to have to come back and be agreed again once we get the guidance from NHS England, which has been promised and I know is in the pipeline, but hasn't yet come. So there was an argument for we could delay reviewing the policy, but there was also an argument that said we should review the policy and make sure that it is as up to date as we want it to be. So there's minor updates to the policy. In regarding to the new guidance relating to conflicts of interest within the ICS, guidance relating to the new provider selection regime requirements, and updated conflicts of interest training for ICBs is to come. The policy itself has been updated to include reference to the working groups like the health and care improvement groups, but it's recommended by the audit committee here for agreement by the board. John, I don't know if you want to add anything to that, but it was probably, if the committee had been able to approve it, it probably would have been agreed in that committee.
Yeah, I've nothing to add. Just to confirm, we scrutinised it as a committee, and we're happy to endorse it. You say it's minor changes at this stage, but we know that there is more. more
Rob, the paper talks about conflict of interest guardian. Is that you in your role, or is that somebody else?
I think that's John.
That's me.
Okay.
Yep.
So it's the chair of the audit committee. And then we talk about developed training. Is that available to all or just NHS people?
So currently, the statutory mandatory training of ICB employees, including the non-execs, is on the Consult.OD portal. And I think it's fair to say that in CCG days, there was additional training that was required of board members, and that's the bit that still needs to be clarified in regard to, maybe a board seminar or additional training that is outside of that statutory mandatory training that we talk about.
Okay, so we're being asked to agree the policy today, but there is some stuff around practicalities about what needs to be done with it that need to come down the line.
Correct.
Any?
This effectively places us as kind of as up to date as we can be, and in as good a shape as we can be if we were to be challenged.
Okay, thanks, John.
That there are further things to come.
Any questions or comments on this paper? Are we happy to support it? Okay, thank you.
Thank you, Chair.
So our final item is questions from the public. Barbara, welcome. I know you sent in a written question. I don't know whether you want to shout that one out to the board, and then we'll try and answer it now if we can.
Yeah, okay. Barbara Harris. I joined the Patient and Public Involvement Group in 2004. I appear to be the last man standing. Well, David's here as well, but I'm the last woman standing, he's the
I am still involved in the NHS, so I've got to be a bit careful with what I say now. So,
19 years, I think, entitles me to sound a word of protest. In the minutes of the meeting of this ICB on the 2nd of February this year, under 6.1 Winter Planning 2022-23, Update and Early Lessons, second paragraph states, and I quote, 3 tranches of funding have been received to support patient flow and the delivery of additional beds. This funding has been used in different ways, including starting the work to increase the bed base by 500. My spirits lift. And further, virtual wards capacity has increased and there remain challenges in discharging patients, and this would need to be optimised to support the system. My question is this: does this ICB intend to increase the bed base by providing community hospital intermediate care beds on the site reserved for the purpose at Frenchay? If so, when? Patients and public have waited 18 years since the plan was announced for an acute hospital, now in place, but we're still waiting for the community hospital provision at Frenchay 9 years after the acute hospital at Southmead opened. When Frenchay Hospital was demolished in 2014, we lost 320 acute beds. When the Brunel building was opened, it was short of 200 beds required. That's according to the previous CEO, Andrea Young. When Thornbury Community Hospital was closed, we lost another 20 intermediate care beds, making a total loss of 540 beds. The population has increased in South Gloucestershire by 50,000 since 2005. I hope the ICB will give a public answer to my question. I'm fully aware that this topic has been lodged as lead with South Gloucestershire Council. To me, that's kicked it into the long grass. It is not the council's function to sort out a matter like this. You are all crisis managing today. And one of the reasons why is you've got insufficient beds. We've had to sit and watch them just go, go, go. And how people like Maria manage that situation with one hand tied behind their back, I do not know. This is a disgraceful situation. I do not understand why South Gloucestershire never qualifies for any public funding. After all, we're paying for the acute ourselves out of income because of PFI. But when it comes to the utilisation of that site, there's silence. Well, I want the silence to end. I want to know if I can go home and tend the garden.
Barbara, thank you for your question. I think probably best to start with Dave. We will give you a written response on your question. I think it'd probably be worth me starting by saying the whole purpose of the ICB is to look at the whole system and look at where we need to make decisions. We do know that finances are never as we would ideally want them to be, and we do know we need to cut our cloth accordingly. That's no consolation to somebody who might need a bed. But Dave, I don't know whether you just want to deal with some of those, and then I don't know whether Shane, whether you want to come in at all.
Barbara rather than the room, if that's okay.
Yeah, of course, yeah.
So Barbara, we'll send you a written response. But I just wanted to confirm, so the ICB, as we have stated, does remain committed to our plans for a new rehabilitation facility on the Frenchay site, and are working hard with partners, in particular South Gloss Council, in forwarding those plans. We are hoping to move to what's called the outline business case stage process within the next year. Okay, that's our current time frame with South Gloss Council. However, as you know, we've discussed before, the proposed Frenchay development form part of our much wider investment in community rehabilitation beds and services in the BNSSG area, and you've heard us talk about those today, and we've debated here at length. The Discharge to Assess and Home First programmes focus on home-based rehabilitation, while for people who need care in a more formal setting, we have also commissioned rehabilitation beds in a range of community facilities and nursing homes across BNSSG. In South Gloss specifically, this includes capacity in the Henderson ward in Thornbury and the Skylight unit in Yate, services provided through Serona. These services are working hard to keep people well at home, and when patients are admitted to hospital, to then support them in returning home as soon as they can, as medically fit. And you'll have heard us debate that at length today, and continues to be a core element of our plans. But in terms of Frenchase specifically, continue to work with South Gloss and aiming to move to that OBC stage within the next year.
Okay. Thank you, Dave. But Barbara, I'm sure you'll want to come back with questions. I don't know whether there's anything anyone else around the table wants to add on it. And, you know, I know these things never absolutely satisfy everybody, but Dave, if we can make sure that Barbara's got that in writing, so at least she can have the clarity on what you've just said. Is there anything else anybody else would like to add to that? And can I just ask if there's any other questions? I don't know, yes.
Yeah, my name's David Chandler. Some of you know me. I emailed Maria before. I do sit on the Health There Together on quite a few health integration teams, and they do work really, really well. The patient public voice is heard, and I hope we can deliver change to help you guys get to a much smoother system. I'm also, this is where I get into a bit of trouble, I also do sit on the Research and Innovation Group, which obviously you fund. I would beg you not to cut funding to research and innovation. If you look at the three big guys in technology, Apple, Microsoft, Google, they never cut research, they never cut innovation. Research and innovation would lead to savings for you guys. It would deliver changes across patient pathways. It will help medics attend patients more better. We've got artificial intelligence coming down the line. I work in the financial industry. You can see it straight across the board now, how artificial intelligence is changing. You put anything into pi.ai, which is a guy by the name of Suleiman who wrote the DeepMind book, who's a revolutionist, basically said it's just going to drive massive change right across the system. What I would say to Bob, and I do sit with Eugenie on some of his groups, UHB, and I always find the medics are always listening to patient and public. They do want patient and public to change how services are delivered. We're not stupid. We know we got financial problems. We know we don't get allocation of funding. I'm glad that all of you took the decision to put bids in to get the diagnostic centres. Obviously, Maria's got the elective surgery going in at MPT, which is great. Eugenie's doing some stuff down at UHB. And you said, Jeff, as well, and this is sum it up, don't think of yourself as individual organisations, because if you do, you'll fail. Think of yourself as one integration system. You're not partners, you're just one system, and you've got to deliver across Bristol, North Somerset and South Gloucestershire. And you will take the public with you. You know, the public are thick. They do understand. I know there's some problems with council workers, because, you know, like Barbara sat on the PIG group, I sat on the Penny Harris's group when she was at the CCG of South Gloucestershire between 2010 and 2014, and you saw the confrontation between council and health. You guys have got to work together.
So can I say your points are well made. We have had countless conversations here around the value of research and the evidence, and I think many of us around the table would say that's where we need to be focusing our attention, because actually otherwise it's anecdote, and anecdote can be quite positive and powerful, but actually we should be responding to the evidence. So we are absolutely committed to the research base, and in Bristol, probably more so than Bristol, North Somerset, South Gloucester, more so than anywhere else. You know, if you look at the networks that we've got set up to deliver that, and I'm sure both Maria and Eugene from the acute perspective would give a very strong answer on that. But Shane, I don't know, you know, we've got a strong research base, so I don't know anything else you want to add to that.
Well, I would just say that actually it's the single strongest research of any ICB in the whole of the country.
Yeah.
In terms of the amount of money that is sourced and delivered, it is actually #1 in the country, which is fabulous. But your point about innovation, actually, we've just started a program with the Academic Health Science Network to really try and accelerate innovation in BNSSG. So they're coming in and working with us, and we're generating what's called the Innovation Hub, because your point is really well made. You know, if we just do what we've always done, it's not going to move us forward. So that's where we're going.
Yeah, one of the things, you know, Jeff and Shane quite quickly is, you know, as PPI, we're learning from other areas in the country as well, what they do best. So if we can import that in here, then obviously we all learn together.
Can I say thank you for coming and making the point? Because
Yeah.
if you don't come and make the point, we do pick it up, but we don't pick it up in the same way, so it's valuable. I really do appreciate it.
And I'll always be on your side, so I promise I'll always ask Professor West and the guy at the University of Bristol to give you a bit more funding.
Oh.
But that does get me into trouble because they say I'm always supporting MBT and obviously UHB.
Okay,
You
look.
should be supporting them.
Thanks very much. Can I move us on to any other business then? Is there anything else around the table anyone else would like to raise? Okay, in that case, I've made us up a bit of time. Our next meeting is on the 2nd of November. So see you all soon.
Thank you very much. Thank you.